Hello, and welcome to the Cottage Center for Orthopedics Meet the Doctor, featuring Dr. James Bailey, an orthopedic surgeon affiliated with Cottage Health. I'm Christina Cortez, the Public Relations Manager at Cottage Health, and I want to thank you all for joining us today. Before we get started, I'd like to go over a couple of housekeeping items to help you get the most out of your experience today. First, at the conclusion of this presentation, we will be hosting a brief Q&A session, so please use the Q&A button at the bottom of your screen to submit your questions. Also, this presentation is being recorded and you will receive an email within the next week with a link to view the presentation and PowerPoint slides. So now it's my pleasure to introduce Dr. James Bailey. Dr. Bailey is a graduate of the United States Naval Academy and served 6 years as a U.S. Marine Corps officer. He then transferred to the U.S. Navy and attended the Uniformed Services University of Health Sciences Medical School in Bethesda, Maryland, and completed his orthopedic surgery residency at the Naval Medical Center San Diego, where he was recognized as Intern of the Year and Top Resident. Dr. Bailey then completed an orthopedic sports medicine and shoulder fellowship at Duke University, where he was an assistant team physician for multiple sports, including the Duke men's basketball and football teams. Dr. Bailey returned to the Naval Medical Center as faculty, specializing in sports medicine and shoulder surgery, holding multiple leadership positions, including Chief of Orthopedic Sports and Shoulder Surgery and Director of the Main Operating Room. In military medicine, he is considered one of the go-to surgeons for complicated knee and shoulder injuries across the Western United States and Pacific Rim. Dr. Bailey served as a team physician for SEAL Teams 1, 3, 5, and 7 during his last few years in the Navy. During his military career, Dr. Bailey traveled to many locations, including 2 Afghanistan combat deployments, serving as the sole orthopedic surgeon at Kandura Role 3 Trauma Hospital. In 2023, Dr. Bailey retired from the military after 25 years of service as a highly decorated military leader, surgeon, and educator, and joined the world-class team at Rue Hurwitz Orthopedic Clinic. He and his partners helped take care of the athletes at UCSB, Westmont College, the Cates School, Bishop Diego High School, and Santa Barbara High School. He is a nationally recognized thought leader and educator in the field of complex orthopedic shoulder and knee surgery. And Dr. Bailey is married to Mary Kate, also a Naval Academy graduate and prior U.S. Marine officer, and they have 5 amazing children together. So now please join me in welcoming Dr. Bailey.
Thank you so much. I really appreciate that. And it's a pleasure to be here with everybody today. Thank you, Leslie, Christy, Christina, Derek, Gary, and the whole team at Cottage for helping put this together. Hopefully we'll have a great little conversation. I'll go through kind of a quick talk here, and then we'll leave plenty of time for any questions that everybody has. So without further ado, let's get started. These are kind of the objectives for today. As I said, it's been a career in the military, so you always have to have an objective slide. So this is what we're going to do. I'm going to talk very quickly about my path that brought me here to Santa Barbara, a little snapshot of my career, and then going to talk about 10 things I think you should know about knee pain, and then get through some final advice. So a little quick thing. My dad was a military brat. We moved all around. He was a backseater in F4s, but ultimately ended up in Anderson, South Carolina for high school. I went to the Naval Academy, then went to Quantico for training in the Marine Corps, went to multiple locations, including Okinawa, Japan. You can probably get seasick here, see all the different places, but ultimately lived in a few different places in the Marine Corps. Then the Navy, I switched to the Navy. They trained me as a surgeon at Bethesda and then San Diego. Went and did a general orthopedic tour up in Bremerton, Washington for a couple of years, and they sent me to Duke for some advanced fellowship for a year in shoulder and knee surgery. And then I went back to San Diego, where I did the rest of my time at the Naval Hospital there, teaching residents and doing surgery. And then that brought me to here after I retired. I've known Dr. Rick Ryu, for many years. We've taught a lot of surgical courses together. And when he found out I was retiring from the military, he asked me to come join the great team. These are my great partners here. Rick Ryu on the far left, and then Graham Hurwitz, Jervis Yao, Danielle Thomas, and myself. We're up on Upper De La Vina. We take care of a lot of the teams here. It's a really great job. So some quick highlights of my military medicine career. First of all, I had amazing patients, amazing partners, had a chance to really kind of elevate my game and cut my teeth and have really top level cases that came to us and just really amazing people to kind of recover, rehab, and that team to allow everybody to recover and rehab. As stated in my introduction, I had the great honor of taking care of active duty military members from anywhere west of the Mississippi all the way out to the Pacific Rim. I was the team doctor for the Navy SEAL teams on the West Coast, and we took care of a lot of the Marine Corps recruit men and women going through San Diego there. The military also gives you a lot of great chances for precocious leadership outside of your years. I went through the Naval Academy, which in itself is a leadership laboratory. We get a lot of low-risk leadership opportunities at a young age in college to really kind of learn what works, what doesn't, watch good leaders, watch bad leaders. And then in the Marine Corps, I was a Marine officer. I had a platoon for a long time and really learned from my senior enlisted and the people that went before me. And then ultimately transitioned into military medicine, had a lot of great chances, as you can see here, to work as department heads, chief of sports, kind of in charge of the OR, and a couple of really amazing kind of highlights of my career, combat deployments to Afghanistan, where I was taking care of amazing people overseas. So why are we here today, and why are we talking about knee pain? Well, knee pain is extremely common main complaint or chief complaint that I see in my office. I'm pretty balanced between knee and shoulder conditions. And then as a sports surgeon, I see a lot of chronic overuse conditions from our athletes, from our weekend warriors, from our aging athletes, anywhere throughout the spectrum of back pain, knee pain, elbow pain, ankle pain, all of it. But my main specialist as a sports surgeon is knee and shoulder. I've given this talk on shoulder, a talk like this on shoulder in the past, so I'm sure you'll be able to find that if you would like to watch it. But this one's going to be about knee pain. So, your knee is our major weight-bearing joint. And when you have a problem with your knee, you have a problem with your mobility, you have a problem with your function. And everything is so connected, as we all know. If you're not walking, if you're not doing your exercise, your heart's not healthy, your mind's not healthy, your body's not healthy. So it's extremely important. It can affect all your aspects of life. So we kind of put together this top 10 things to know about knee pain. There are probably 100. We're going to talk about 10 right now. And I try to boil it down to some of the important things. So anatomy, at the very basics of anatomy, you've got the knee joint connects the bones, right? The femur and the tibia. And then you have the ligaments on the inside and outside, which provide the stability of the knee, kind of side to side and rotational stability. The cartilage that's in your knee and the meniscus that's on top of the cartilage, that cushions your movements. And then the tendons and the muscles kind of support your mobility. They support your power. They support the joint. We got a little video here we'll watch. Kind of goes over some great anatomy and great animations to kind of go through it. So kind of your muscles, your bones, your muscles, your tendons, your ligaments, kind of supports your mobility and your ability to participate in activities as we discussed. So kind of the knee is a hinge joint, and then it has a patella, which also helps with your ability to extend your knee and give your knee more power. You have the condyles and the plateau of your knee from your femur and your tibia. That's where all your cartilage lives. You have a groove in your femur. That is what your patella or your kneecap goes back and forth on as you perform your motion. Your fibula is the small bone in your lower leg that provides some kind of structural support of the leg, but not as much as the tibia. Here we're going to show you the articular cartilage. Your articular cartilage is extremely smooth surface that allows for the gliding of your knee back and forth thousands of times a day. Synovial membrane kind of creates some of the joint fluid, which allows it to be nice and smooth. Your meniscus is over your cartilage, and that kind of supports your knee. It's your shock absorbers of the knee that we kind of talk about. So when you're pounding your knee or going on that run or you're going up and down the stairs, that meniscus protects that cartilage. It kind of supports that knee, and it allows for some of that that loading of your weight bearing. And then again, we talked about these, collateral ligaments and cruciate ligaments. Cruciate means crossing. So you're crossing anterior and posterior cruciate ligaments, and your collaterals on the outside, your MCL, your LCL that we commonly talk about. There are multiple more of these ligaments, but these are kind of the main ones we talk about. Your cruciates allow for that A to P, that anterior to posterior, but also that rotational stability. So when you see someone talk about rupturing their ACL, they have not only anterior to posterior instability, but that rotational instability of the knee. Then what's our powertrain, right? What's the engine of this? And that's the muscles. And the muscles connect to the tendons, which ultimately connect to the bone and help with the motor function of our leg and allows us to walk. So you have your quad in the front, you have your hamstrings, and these all come together to allow us to be functional and moving. That's 10, right? So in reverse order, 9. Really, these are in any general order because they're all important, but a good exam is very important. And this is similar to the shoulder. There are a lot of things that can cause pain in your knee. There are a lot of pain generators in the knee. And so we need to kind of tease those out and figure out what's your problem. We don't treat MRIs. We don't treat x-rays. We treat people. So when you come in to see me or any of the surgeons in town, we have great surgeons in town. They're going to look at you as an individual, and they're going to do a good exam, and they're going to figure out what's causing you these problems, because it can be a lot of them. So you have to keep organized. You have to keep things in order, to keep them in boxes, as we say. And there are a lot of ways to do this. I've got a little video here.
So
I won't talk over it.
Thank you very much for being a test patient here. So first of all, we're going to start off by
knee exam.
Evaluating and looking at the skin, the alignment of the legs, looking to see if the alignment's straight or if the patient is knock-kneed or bow-legged. That has a lot to do with what could be causing problems or just how they're born. If it's symmetric side to side or if it's not symmetric. And then we also look for surgical incisions or any kind of traumatic incisions, if the knee is swollen or not. One of the best ways to look for swelling inside the knee is to just kind of push down and feel the soft spots of the knee here, and always compare side to side to look for any swelling in the knee. And then after we've done kind of visual exam of the knee, we can start by range of motion. So we start here and you can see if they have any hyperextension. She has a little bit of hyperextension in the knees. Always check the other side to know what's normal and what's not normal. So her normal range of motion is about 5 degrees of hyperextension, and we're going to bend her up, check her knee range of motion. She's got great flexion. And I feel the kneecap, and I feel if there's any grinding under the kneecap or on the sides of her knee throughout range of motion. We'll put that right here. We'll check the other knee. As you can see, very symmetric kind of flexion of the knee. I'll bring those down. And then next thing, put the knee at 90 degrees. Check the meniscus right along here. You can walk down the condyle right into the meniscus. So medial meniscus right here all the way to the back. Lateral meniscus here. See if they have any joint line tenderness on either side. You can do a McMurray's, where you really pinch the inside of the knee and the outside of the knee to see if there are any meniscus problems on one side or the other. Again, checking with the normal knee. And then it comes down to ligamentous exam usually. So first thing you can do is check the ACL and the PCL, which are your central ligaments. So I usually check it with the knee bent slightly, put my fingers on the joint line, and make sure there's a nice clean stop. of the ACL. That's a Lachman exam. Feels really good at 90 degrees. You can check the posterior drawer for the PCL or an anterior drawer for the ACL. That feels good. Again, check with the other knee to see what their normal is. And then we're going to check the MCL and the LCL structures. So at 0 and at 30 degrees, you check valgus and varus stress. And you're going to feel to make sure there's a nice solid endpoint. And you're going to check and see how much the knee opens up. Then we're going to go to the other side and we're going to check the normal knee. And we're going to measure that to see how much side to side. Also, when you're doing these, you'll ask, does this hurt?
No.
Yes. No. And side to side. So that's kind of general knee exam that I do with every single knee when someone comes in with knee pain. Thank you.
All right, so a little snapshot in what I do multiple times a day with the knee exam. Same thing every time. No exam is perfect, right? So no exam is like, oh, this is 100% when you have. So you need to kind of put all of it together, as well as the history, the complaints, and then usually images to come up with a perfect diagnosis. Number 8, sprains, strains, overuse, right? Tendonitis, bursitis. Extremely common. Sprains and strains commonly caused by either sudden twists, falls, blows, really common in sports or athletic activities. The tendons or ligaments can either overstretch or they can tear partially. And the symptoms, usually you complain of pain, swelling, instability. Overuse often leads to inflammation of the tendons, the bursa, inside the knee joint. It's pretty common with occupations that require frequent kneeling or runners, cyclists, stuff like that. It's usually pain that's increased with activity, motion, pressure, stuff like that. The outcomes of these depend on a lot of things, as you can see here. Your chronological age. We tend to look at people for their physiologic age. Age is just a number, right? 60 is the new 40, right? So we want to look at, how old are you? Because that does say something about your healing capacity, your blood flow, etc. But your physiologic age as well. What do you like to do? How active are you still? That can go both ways, to be quite honest. And really, like, your goals. What are you trying to get back to? What do you want to get back to? Those are all really important decision making tools when we decide what to do. All right, number 7, really common meniscus tears or meniscus injuries. One of the most common causes of acute pain and chronic pain in adults. It can happen from very acute injuries, usually bending, twisting type injuries, or it can just be overuse, chronic degenerative changes. Not all meniscus tears are the same, right? As you can see down here, there are a lot of different types of meniscus tears. So when your friend says, oh, I had a meniscus surgery and they repaired it. And someone says, I had a meniscus surgery and they just cut it out. There are a lot of things that goes in. There are a lot of details that go into that. And most of it depends on the meniscus. We know the anatomy of meniscus. We know the blood supply comes from the outside of the meniscus. So these little tears on the inside, these chronic degenerative tears, I could put 1,000 stitches in those and they would never heal because the blood supply is just not there anymore. So those are very common that we just kind of trim those parts out. We leave all the healthy meniscus. And but the tears around the back where the blood supply is, those were a lot more likely to fix with some stitches. So, treatment. And this is going to be a common theme with this. Actually, we'll go back to this. So, most of what I see is elective. The treatment for it is elective, right? It's not cancer. It's not going to kill you. A lot of it depends on your goals. What have you done so far? Where on the treatment ladder do you want to start? But that treatment ladder usually is the same for most of these problems. You'll see a common theme, tincture of time, watchful waiting, physical therapy, injections, and then we get into the surgical options. For meniscus, there are multiple surgical options, like we talked about. We can clean off the tear. We can repair the tear. If the whole meniscus is torn and you're young, we can replace the meniscus. And then there are surgeries we can do that are remote from the meniscus to help it, like realigning the knee, realigning the leg if it's overloaded. So here's a quick little picture from one of my scopes of a meniscus tear. This is one of the meniscus that's kind of in the back, closer to the blood supply. And you can see that would obviously, every time you bend your knee, that would cause a problem, and that would cause pain. I say that these tears aren't necessarily painful, but when you pull at them, they are kind of like a scab. Here's just kind of the treatment that I did for this. It's just kind of the all inside, all suture anchors that, a lot of us use. Various different companies make them. And, it's got a dial on the back of it that you can't see that is pushing in the implant and flipping the implant and kind of stabilizing that. So now I have one in there, and I'm going to go to another part, put it in there, and then flip that dial again to kind of flip that knot. And now I've got a double repair stitch. So you'll see the first one tighten up, and then you'll see the second one tighten up. And that's kind of that repair of that part of the meniscus. And I went on to put a few more in there. As you can see, that tear propagates. All right, ligaments, tendons. As you can see, a long list. We have a lot of them. Alphabet soup here, right? They all mean something. This is, unfortunately, a Marine I took care of that was run into by a car and dislocated both of his knees. So all of these ligaments were torn in this poor gentleman. We had to reconstruct both knees, all these ligaments. But this is kind of that exam you can see of multiple different ligaments torn. And this is when you can't put your head down in the sand. You got to kind of evaluate each one. You got to come up with that complex plan of how are we going to treat all these? Which ones are we going to do first? Are we going to do them all at the same time? These ligaments and tendons, as we talked about, they kind of help stabilize the knee, and they help attach the muscle to the bone for the tendons. So they're very important. Same kind of treatment algorithm, right? It kind of depends on a lot of things, and that's something that we would discuss, obviously, or you and your surgeon would discuss, depending on what type of tear is it, what's torn, is it a partial tear or a full tear? Can we start with some physical therapy in time, or should we kind of go to surgery? This is a video that I have out there on a ViewMedi, which is kind of a surgeon-based portal that you can go to watch a lot of different surgeries on posterior lateral corner reconstructions for torn ligaments. Okay, the patella, the kneecap, broad spectrum of problems when it comes to the kneecap. Everything from just inflammation from a kneecap that's not tracking well to a dislocating kneecap, as you can see on this one. I'm going to redo that one again. And so you guys can see as she's coming up and down, you can see the kneecap go from out and then pop into the track right there. And you'll see one more as she's kind of coming up. It goes out, and then it's popping back into that trochlea or that groove. So again, a really spectrum of treatment for these kneecap problems, but they're extremely common. Maltracking is extremely common, and it can cause pain. It can cause grinding or crepitus under the knee, and it can be really disabling and kind of affect your activities. For most of these, even a first-time dislocation of the kneecap. And so when people talk about dislocating their knee, it's very important to know, did they dislocate their kneecap or did their whole knee dislocate? Very different problems. But these kneecap dislocations or patellar instability or patellar dislocation, even for that, the mainstay treatment for a first-time dislocation is often physical therapy, depending on a few different things. But usually we try and see, hey, can you stabilize that kneecap with physical therapy? Sometimes we'll talk about injections, but then we have a host of surgeries for that as well. these two pictures, you can see an MPFL reconstruction, medial patellofemoral ligament. So that's the main stabilizing ligament on the side of the knee that keeps that kneecap going in line as you're going through your range of motion. It's a static stabilizer, or a check rein, we call it. When you have chronic instability, one of the things you have to do is reconstruct that ligament. And then sometimes your alignment is off, your knock-kneed. So your kneecap is constantly pulling lateral or outward as you walk. So sometimes with that, you have to do the picture on the right, which is a case of mine where I had to cut the femur, open up the femur, put a plate on it, and then let that femur heal. And that realigns that leg so that the chronic pull is not pulling the kneecap out. Arthritis. Osteoarthritis, many different types of arthritis. Osteoarthritis, obviously the most common type of arthritis. It also is a spectrum from early cartilage wear and tear or chondromalacia to having full-on flattening of your condyles or your knee, big osteophytes on the side of the knee, and chronic swelling and inflammation. Osteoarthritis is a very, very common thing we see in clinic. And big surprise, the treatment algorithm looks pretty similar to what you've seen before on these other problems. One of the things a lot of people ask about is injections for arthritis. For the knee and for arthritis, we have kind of three main types of injections. We've got cortisone, which is steroid. So you can hear it called by many different words, but essentially steroid injections. We've got viscosupplementation, which you often referred to as gel injections or hyaluronic acid injections, which is what it is. And then we have biologic injections. We'll talk a little bit more about that at the end of this talk, but things like PRP, BMAC, those stem cell-like injections that people talk about. So very briefly, cortisone is an anti-inflammatory. It's great for an inflamed knee. It helps with pain and inflammation. It often can help you make some more gains with physical therapy. It's not doing anything biologic in your knee other than helping with inflammation and pain. And sometimes that's what you need. And it's covered by most insurances, which is a benefit. The hyaluronic acid is something that your knee already makes. But when you have arthritis, your fluid content in your knee and your hyaluronic acid content in your knee is much less. So we can do these gel injections, which is kind of like an oil change in your car. It's a thick viscose supplementation, or a thick viscous solution of hyaluronic acid that we inject in your knee. And it can help with tracking. It can help with smooth motion. It can help with inflammation and pain. And it's a really good option. Medicare, one of the nice things of Medicare is it will pay for this every 6 months if you have full Medicare. So that often plays into our decision making when we're talking about injections. A lot of the private insurances and other insurances don't pay for this, and it can be pretty expensive. So that comes into the decision making when we're talking about it. And then PRP and biologics, we'll talk about that a little bit later, but it's taking your own tissue, your own blood, your own kind of marrow. It's concentrating that in a centrifuge, getting those growth factors and those healing factors out, and then injecting that in the knee to kind of help stimulate a healing environment and healing response. Arthroscopy. So I do a lot of arthroscopy. I'm a sports surgeon. I'm an arthroscopist. So I learn how to do surgery through small poke holes with a camera and arthroscopic instruments. For early arthritis, it often is a reasonable option, especially if you have something that comes very commonly with arthritis, which is meniscus problems or meniscus tears. So if you're having painful mechanical clicking, catching, those kind of symptoms in the knee, I can go in with a little camera. A lot of us can and go in with a little camera, and we can look at everything in your knee. We can look at your ACL. We can look at your PCL. We can look at your medial meniscus, your lateral meniscus, and we can look at the cartilage on your entire knee, and we can treat whatever we need to treat arthroscopically. Now, obviously, there are limitations in that, but that can often help with early arthritis, meniscus problems, and other issues like that. And then we talk about knee replacement. I've got another slide here. So full knee replacement versus partial knee replacement. That's something that people ask a lot about. And these are kind of two pictures of it. Obviously, at the very basics, a full knee replacement is indicated when you have severe end-stage arthritis on all the parts of your knee, or at least kind of two parts of the knee. And a partial knee replacement is when the rest of your knee looks pretty good, but maybe the inside part of your knee, or maybe your patellofemoral joint has some wear and tear, or significant wear and tear. So this is a very good surgery. The problem is, the reason why we're not doing this, just replacing knees on 30-year-olds and 40-year-olds, which unfortunately sometimes we have to do if they have a very, very, very severe problem. But there's a shelf life on this. It's metal and plastic, and it doesn't always last you your whole life. So if you get this done when you're young, you may need a revision in the future, and that's a bigger surgery. So that's why we have a lot of all these other options that we can talk to you about until you get to the age where a knee replacement is a very good option. As you saw on many of these slides, non-surgical management is a very common treatment. I'm a surgeon. I love doing surgeon, right? They say to surgeons, all the world's a nail and I'm a hammer. It's not really true, but I do love doing surgery. It's one of my passions in life. And I love meeting people, and I love talking to people, and I love treating people for their problems and trying to get them back to a healthy lifestyle. And more times than not, that is with non-surgical options. So physical therapy, different modalities, massage, chiropractic treatments, acupuncture, and then we get into, other options such as bracing. We have lots of bracing options for arthritis and instability in the knee, and then injections like we talked about. So there are a lot of different options besides just surgery. So going to a surgeon doesn't mean you're getting surgery. It just means that you're going to have someone that can talk to you about all the options available to you. And if they only talk to you about surgery, you may be in the wrong place. So what's new? That's what a lot of people want to know about. What's coming out there? Everybody comes into my office. They said, I saw on TikTok or I saw on Instagram, there's this new gel that they have in Germany or Bulgaria or, a variety of different, countries, which the AI and the big social media platforms have kind of put forward, not the platforms themselves, but that has gone around out in social media. And it is true. There are things out there outside of the United States that we don't have access to in the United States. That is usually for very, very good reason, though. We have a very robust FDA. They make sure that things that we are putting in your body are FDA approved and that they're safe, because it hasn't always been that way. So because you might be able to get something somewhere else doesn't necessarily mean it's the right thing for you. So biologics. We talked briefly about that. There are a lot of different types of biologics. Always happy to talk to patients about them. They are not the panacea. They are not the, next best thing since sliced bread. They don't fix everything. They don't make you 18 years old again, but they're pretty good for the right problem. And that's what's important is going to someone that you trust that can tell you, like, yes, there's pretty good literature to support the use of, say, PRP, which is platelet-rich plasma, which is I draw your blood in clinic, I spin it, I get the concentrated platelets out of it, and we inject that into a body part. That costs money because insurance doesn't cover it. So anytime there is a fee to that, there is going to be secondary gain. So you want to make sure you go to someone you trust that can kind of tell you, this might help you, or this is unlikely to help you. It may just cost you money. If there are questions at the end, we can talk about those because it's a big topic, and there are a lot of different types of biologics, from bone marrow to fat, and even embryonic cells that people talk about being stem cells, and we can get into that in the future. Ultimately, at the very basics, there are no FDA-approved stem cells in the United States unless you're part of an approved FDA study. And there's also not great repetitive literature to support one of these injections over the other. There may be science at the bench level that there are different improved cells in one type of injection or another, but the clinical studies seem to support that all of these injections do pretty well for the right type of problem. All right, custom technology, assisted surgery, robot surgery, those kind of things. There are a lot of companies that you can go with that provide robotic assisted surgery. Cottage has a robot. Our surgery center has a technology assisted surgery option. They're really neat tools, and that's what they are. They're a tool. They can help to plan your cuts for knee replacements or partial knee replacements. They can help be very precise with those cuts. In the end, the literature, the peer review literature that is out there, that has not shown reproducibly that the outcomes are much different from robotic surgery or non-robotic surgery. The main thing is that you want to go to someone that is comfortable doing one type of surgery or the other, and that you're comfortable with them. Okay, this is a new thing that's kind of out there and pretty new. This internal shock absorber. It's a Misha. I don't have any stock in it, and I'm not a consultant for it. But it's an internal shock absorber in the knee that goes on the inside of the knee, which is most of where, as we age and get further away from 18 years old, most of us will develop arthritis in the inside of the knee as opposed to the outside of the knee. That's not everybody. Some people are knock-kneed and it happens on the outside. This implant is specifically for the inside of the knee. It goes under the skin and it actually acts as just a shock absorber and takes some of the weight off of your knee. So another thing that I will often talk to my patients about, and you may have been talked about before by your doctors, is braces that unload your knee. So an unloader brace that sits on the outside of the knee. That's essentially what this is doing on the inside of the knee. It's meant for knees that look like they need a partial knee replacement on the inside, but the patient's too young, or, this patient's still extremely active and is a runner, and you don't want to, have a partial knee replacement that's going to wear out too soon. So there's still a lot coming out about this. It seems to have pretty good outcomes so far, and a pretty good, 5 to 10 year survivorship of needing to then take it out and put in a knee replacement. It's not really meant to be something you have your entire life. Likely the rest of your knee will break down with time. And that's kind of something that we just see with normal aging. And when that happens, you just take this out and you put in a knee replacement. Let's see. Also, how am I doing? Cartilage replacement. I'm a cartilage replacement surgery. I do a lot of different types of surgeries for younger patients that have focal, well kind of defined cartilage lesions in their knee. So not full on arthritis, but a cartilage defect from an injury, or they were born with a lesion in their knee that never quite healed, which can happen. And there are a lot of different ways to address that. And we don't have time to get into all of that, but you can take a piece of cartilage from the knee and send it off to a lab and grow a matrix, which then I put in the knee, and it helps grow the cartilage back. Or we can take a plug of cartilage and bone from a cadaver from someone who recently passed away. It gives us about 10 to 14 days to then put it in somebody else's knee. I did a lot of those surgeries in the military, and still have done a few here in Santa Barbara. And then edema. So as you can see, the far picture on the right, again, I'm not a consultant for this company. You can see all the white in the dark bone. What that is that's bone bruising. That's fluid. That's fluid inside the bone. It's because of a cartilage lesion. You can see that there's a really high intensity or high signal right at the cartilage level. That's where there's no cartilage. So that bone underneath it is seeing more stress than it wants, and it's not happy. You can see the picture after they've been treated with these kind of osseous kind of bone replacement dowels. So it is possible that your pain in your knee is coming from a bad bone bruise. And sometimes those don't heal on their own. And we have these kind of newer techniques for treating that. Lastly, when should you come see me, or when should you go see your doctor or your surgeon for your knee pain? Kind of some simple rules, right? If you're not sleeping, you're having pain at night, that's not good. We all know how important sleep is. Sleep affects so many of the functions in our life. If you're having problems sleeping because your knee is keeping you up, or you're rolling around and it's waking you up at night, you should seek care for that. You can't do the activities you used to want to do, you used to enjoy doing, right? You're not active, you're not healthy, you're worried about all those things. You should come and see someone for that. And then listen to the people you trust. They see you all the time. They notice you limping. They notice that you've changed. Sometimes we don't. We live with it day by day. We don't really notice it. When someone says, "What's wrong? Why are you limping? You're not doing as well." Listen to them and go see someone. Here's some resources which are really good. You'll all get this presentation later, so you can look at those. And I just want to thank you for your time. Happy to open it up to questions. Hopefully this was beneficial in some way for all of you. This is my website. It's got a lot of patient information on there that you can go to and look up videos and other things. So with that, I will unshare my screen. Thank you very much.
Thank you, Dr. Bailey, for that very informative and interesting presentation. We'd now like to move to the question and answer session. So we have a few questions, so we'll do our best to get through as many as possible. If you haven't done so already, please put your questions in the Q&A box at the bottom of your screen, and I will read them off to Dr. Bailey. Alrighty, Dr. Bailey, we're going to start off with our first question. Can physical therapy fix my knee problem?
Yeah, I mean, that's a great question. It depends on what's wrong. And it's very unlikely that physical therapy is going to make your problem worse. If you have a good physical therapist that's going to evaluate you, they're going to see what you can and can't do, and not push you past that until we have a good idea of what's wrong, right? So physical therapy is a mainstay of treatment for overuse injuries, for sprain strains, for tendonitis, and often I will see someone for one of these problems, or you see your primary care doctor for one of these problems as well, and they prescribe you physical therapy and you get better, and that's all you need. So yes, it is very possible that physical therapy can help you, if not fix the problem.
Okay, thank you. And while we're in the subject of movement, what kind of exercises are safest for arthritic knees?
Yeah, great question. Motion is lotion, right? We want you moving. We want you to be active. We don't want you, laying in bed and not going out and getting fresh air and getting some sun and all that kind of stuff. But once you start developing kind of activity limiting arthritis, we usually do recommend trying to stay away from impact type activities. Your knee, I trained with a surgeon at Duke, and he used to say, you only have so many heartbeats in your knee, right? And you need to decide how you want to use those heartbeats. So if running is the only thing you want to do, like Mike Swan's out there, he's a physical therapist, he's big runner, right? The only thing he wants to do is run. And if he's got arthritis in his knee, I'm not going to tell him he can't run, right? He's going to run, but it may progress that problem quicker. So you got to decide how you want to do. And if you're able to do more non-impact activities, swimming, elliptical, bicycle, those are usually a little bit better for those arthritic knees.
Okay, perfect. Thank you so much. And our next question, is it more difficult getting a total knee replacement after first having gotten a partial knee replacement?
Yeah. Well, I mean, any revision surgery is a little bit more tough, from a surgical side. We're not going through fresh tissue. We're going through scar tissue. Usually the knee or shoulder is a little bit tighter than it was. When you do a partial knee replacement, the downside of transitioning to a total knee replacement is sometimes you lose a little bit of bone from taking that partial knee replacement off. So sometimes we have to use a little bit bigger, poly or the plastic piece. But in general, it's very common. It's a very common surgery to have to transition a transition to a total knee replacement from a partial. I don't think it needs to be something that keeps you up at night, but if you are a much better candidate for a partial knee replacement, the knee will feel much more normal to you than a total knee replacement. With a total knee replacement, we keep those collateral ligaments on the side. Sometimes we keep that PCL, but that ACL is gone. And so, and now you have metal and plastic. So even though it's a very, very good surgery for the right people, and people love that surgery when it's done in the right patient population, it always feels a little bit mechanical, right? It always feels a little clicky, click, 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 kind of like that. A little bit different than a hip replacement because the hip is buried in so much muscle and deep in your body. The knee's right under your skin, right? So a partial knee replacement in a young person is going to feel a lot more normal to them than a total knee replacement.
Okay, thank you. That's very informative. All right, for our next question, if someone feels knee pain only when going downstairs, but not while walking, what might be causing that? Could it be arthritis, wear and tear?
Yeah, it's a great question. And that kind of gets into what I was talking earlier, that none of these exam findings are perfect, right? So we do a good exam, we do the best one we can, we use images, we do all those things, but the history from the patient is important. It's very important, right? So you tell me you don't have any pain walking, maybe you don't have any pain running, but your pain is going downstairs or going upstairs. That's usually pointing to patellofemoral, a kneecap problem. Or it could be pointing to a PCL problem. So when you are going downstairs, your femur is pushing forward on your tibia. And if you have a PCL tear, you have nothing to stop that. So people with PCL insufficiency or PCL tears will usually say they have problems going down hills or going downstairs.
Okay, thank you for that. Mm-hmm. We have a question here about an old ACL tear that was never repaired. Is surgery still an option, and would the approach be any different?
Yeah. This is when we're going to look at everything involved in this problem, right? Mm-hmm. So old ACL tears, old can mean a lot of things. That can mean 6 weeks ago. That can mean 60 years ago. When you have an ACL deficient knee, you have micromotion in the knee. You have micro instability in the knee. That can lead to problems with your meniscus, and it can lead to further degenerative changes in your knee. So if you are 70 years old and you tore your ACL when you were 20, and now you have no ACL, but you also have arthritis in the knee, the ACL is the least important thing going on right now. But if you are, 40 or 50 and you had an ACL tear, 10 years ago, 15 years ago, 5 years ago, and your problem, you come to me and you say, it feels unstable. It feels like it gives out on me. It shifts on me, and you don't have really severe arthritis. Then no, we do the same thing. ACL reconstruction, stabilize that knee, get you back to your activities.
Okay, great. Thank you. Mm-hmm. Is a physician referral required to initially see you or another provider at the Cottage Center for Orthopedics?
Yeah, great questions. A lot to unpack there real quick. So it kind of depends on your insurance. It's not really about us. There are some insurances that do require a referral to be sent to us by your primary care doctor. People that don't require a referral for a specialist then can just come see us directly, just call us and come right in. So it kind of depends on PPO or what kind of insurance you have. If you have any questions, you should talk to your insurance about. And then For me specifically, in my group, we're not actually at Cottage, Cottage Orthopedic Center of Excellence or anything like that. We're at the Ryu Hurwitz Orthopedic Clinic, but that's just one option for you.
Okay, perfect.
Yeah.
And then I guess around the same topic, have you known insurances to require folks to go to physical therapy prior to seeing an orthopedic surgeon?
I've never seen them require you go to physical therapy before you see me. Mm-hmm. But it is kind of, unfortunately, sometimes common that insurances won't approve surgery before you've had 6 weeks of failed physical therapy. That's kind of a something we see on occasion, and sometimes that's for very good reason, because as we talked about before, sometimes your problem will go away after physical therapy. But when you have a bad problem like a torn ligament, something that we know is not going to get better, if they deny that, then that's when we get on the phone with insurances and we do a peer-to-peer phone call, and they usually reverse that.
Okay, great. Thank you for that information. Is there any benefit to taking glucosamine for knees?
Yeah. So glucosamine chondroitin, it's been around for a long, long time. A lot of the mechanism of why it helps is a bit not understood. And also it's a nutraceutical. So it's not a pharmaceutical, so it's not controlled by the FDA. So the downside with any nutraceutical is you don't always know what's in it, right? So you want to make sure you go with a reputable brand. Also, when I was in fellowship, one of my staff had done a study looking at multiple different types of this medication, and they found that it had varying amounts of the actual active ingredients in it. So Cosamine is a brand they found was like the highest purity of content. That was many years ago. It could have changed, but I do know that that's a brand that they sell at Costco and other places. So it seems to be a very reputable brand. It's the only advice I have on that. I also do not own any stock in that company. In no way am financially benefited by that. And feel free to look at other brands. But I have heard that that's a really good one. And what I usually tell people is try it for a month. Listen to the instructions on the bottle, try it for a month, and then go off of it. If you feel better, then great, do it. But if you're not sure you have any benefits, go off of it. Sometimes you'll find that, oh, wait, that was happening. That was helping. Just don't do it at the same time as another, something else you're going to do, because, with anything in life, you don't want to pay for something that's not helping you at all.
Okay, perfect. Thank you. We have a few questions regarding the injections you referenced. Yeah. One is, what is the maximum number of cortisone injections that one can have or receive in the knee?
Yeah, there's not really a maximum. Some people will say there's a maximum. It's there's not really a maximum. It's all a risk benefit discussion that has to be had. So steroids are, like I said before, very potent anti-inflammatory. They have a very good role with certain conditions. For arthritis, we used to just do steroid every 6 weeks, and what we know is that it's not the most healthy thing for your knee. Repetitive steroid injections. In the laboratory, we know that repetitive steroid exposure to cartilage can cause, cartilage thinning, can cause tissue degradation. But in some people, it's really the only option they have. They don't want to get surgery, or they're too sick to get surgery. Their insurance doesn't cover hyaluronic acid. And hyaluronic acid and the biologic injections are just too expensive for them. And that's just a reality of what we live in, right? So when I do steroid injections, I try and tell people they shouldn't get it more frequently than every 4 to 6 months is what I try and recommend to people.
Okay. Thank you for that guidance.
Mhm.
And can you clarify? Someone is asking if they heard you correctly say that Medicare does cover gel injections several times a year.
So Medicare, if you have full Medicare Part A and B, obviously, talk to your provider that you're seeing to make sure. But to look at your insurance and make sure there's, because there are some variations of Medicare. Um, and that is outside of my pay scale. But if you have Part B, full Medicare, they will pay for the hyaluron or the gel injections, hyaluronic acid injections every 6 months.
Okay, perfect. What is the shelf life of a full and partial knee replacement, like comparing?
Yeah. I mean, the kind of our implants and the technology we have continues to improve. And so when you're looking at long-term outcome, when you're looking at shelf life, you're usually looking at a study that's 10 or 15 years old, right? Because that's the only way you know a shelf life, right? So we have pretty good 10 to 15 year data on total knee replacements. Have to look at the data for partials, but probably somewhere similar, till transition to a total knee replacement, 10 years plus. We hope that with the newer kind of materials we're using, there are different types of metals or different types of kind of polyethylene, putting vitamin E in it, all these different things that people are trying, that maybe we can get, we're going to get to that 20, 25 year survival rate of a knee replacement. And then it's going to be, less of a concern to us of when people have really bad arthritis in their 60s or even 50s, of doing these surgeries.
Okay, thank you for that. This is an interesting one. How much time is enough time to see if the knee can self-repair?
Yeah. I'll tell you, I mean, I'm the worst patient. I'm the worst patient. I've lived with problems for, a long time, that I have. I tore my meniscus in Afghanistan and my labrum in Afghanistan. I couldn't do anything about it, and they got better. I'm not kicking down doors. My job is a surgeon, right? So it depends on a lot of things. It depends on what that patient needs to do day to day to survive for their income. Someone who's an accountant, a very, very important job, has a very different job than someone who's laying bricks every day, or doing manual labor. So this is where ChatGPT doesn't always work, right?
Mm-hmm.
There are a lot of details that go into this decision making of acting on something or not. So in general, like, I usually give problems a bit of time to see if they get better. I would say swelling is a good indicator, right? So if you have a really swollen joint, you hurt something pretty bad. That may be something you want to get in to see someone soon. If your knee is flopping around or pointing in the other direction, which I've seen, you need to see someone right away. But these aches, these sprains, these strains, these overuse injuries, the body is an amazing organism. It will fix a lot of things with some watchful waiting and time. But, we're here to kind of help support that.
Perfect. I'm going to try to tie two questions together because we're running close to our time. Mm-hmm. Do you recommend taking collagen? And how do you feel about red light therapy for inflammation?
Yeah. Well, my wife does red light every day. She loves it, right? So, and I have done it 0 times. It's probably because I'm lazy, but I think there's some great data on inflammation and kind of tissue recovery with red light therapy. There are some great places in town that kind of are doing kind of the whole longevity, using different modalities to kind of help with tissue regeneration, tissue healing. So I think all those things are great. I don't think they're available to everybody. But if they are available to you and they are not causing harm and you feel they're making you better, I also think the mind is a very important, a very amazing organism that we have in our body too. So all those things can really help you kind of on your way to recovery. I think there's some pretty good data on red light. But it is a bit outside of kind of what I study and what I focus on day to day. Collagen, the same. Collagen, creatine, a lot of these nutraceuticals or a lot of these additional kind of supplements can be very helpful in healing and tissue regeneration. I partner with a nutrition company. I do have a nutrition company that I partner with. That if you came and saw me in the office, you would see that I use them for pre and post-operative optimization of nutrition. I think that is super helpful and very beneficial. But again, it can be expensive. So I also tell people, eat healthy, live a healthy life. Make sure you're getting the nutrients and the vitamins that you're in your diet. And if you're not, supplement with a multivitamin.
Okay, thank you for that.
Mm-hmm.
This one's a little subjective, but if someone was an active, let's say, tennis player before having a knee replacement, does their level of activity prior to surgery impact how quickly they'll be able to return to those activities after surgery?
Yeah, 100%. Right. So your range of motion before surgery is going to predict your range of motion after surgery. Your fitness level before surgery is going to predict your fitness level after surgery. There's a whole concept of prehab or, pre-surgery physical therapy and rehab. Not all insurances will pay for that. But, if you're healthy, you're active, you're living a clean life, you're doing all those things, that's gonna help you when it comes to rehabbing from surgery. There's a caveat to that is, make sure that your surgeon is setting realistic expectations with you when it comes to your injury, your surgery, and what to expect after surgery. So very, very young, active people, if you look at the literature, are not as happy after a knee replacement as are kind of older, amazing, adults that just want to go back to maybe playing 9 holes and working their garden and, being around the house and going for walks around the neighborhood. They are super happy after a knee replacement. But, if you are expecting to go back to running marathons and doing various different things, that can be difficult after certain surgeries. So, make sure you have someone that's kind of, kind of setting those expectations up front so you know what to expect after surgery.
Okay, thank you. That's good advice. I think we have time for one more question before we wrap up. So I'm going to tie 2 questions together again. What inspired you to specialize in knees, and are you accepting new patients?
Yeah. Well, so I actually went into medicine wanting to be like a family practice doctor, small town doctor, hang a shingle, see everybody, and work in a small town. I shadowed some doctors when I was in high school. When I went to the Naval Academy, I remember sitting down in Alumni Hall with all of my fellow freshmen or plebes, and someone with a lot of stripes on their shoulders saying, if you came here to be a doctor or a lawyer, you are in the wrong place. We train warriors here. And I was like, well, I guess I won't be a doctor. And so I was a Marine for 6 years. And when I was in Okinawa, Japan, I was working with a lot of the mishap prevention doctors, looking at injuries in Okinawa from our Marines going surfing during typhoons and pulling over vending machines on themselves. And that's when kind of some of those people told me about the programs that the Navy has. I also was in Kenya working on doing some war games in the Marine Corps, and I spent a day with the doctors going out to the villages and helping treat people in the different villages. And I just really kind of got that passion back again for helping people and wanting to kind of be there for people during their tough times. And so when I went to med school, I kind of thought I wanted to be a family practice doctor, and I think I would have been very happy there. But during med school, you rotate in all the different specialties. And when I was rotating in surgery, it just clicked. I just knew that's what I wanted to do. I wanted to work with my hands and objectively kind of change people and help them and kind of get them back. And then throughout all the different types of surgery, orthopedics just really clicked with me. I played sports my whole life growing up, and the kind of injuries and the surgeries that we perform just made a lot of sense to me. So that's when I really decided I want to go into orthopedics. And it gets further and further down the rabbit hole, but ultimately arthroscopy, working minimally invasive, doing things with a little camera in the shoulder and the knee is just something that I really enjoyed doing and wanted to kind of specialize in. And yes, I'm accepting new patients. So happy to see anybody out there.
Perfect. All righty, Doctor. Thank you so much. That concludes our Q&A session. Thank you for the great presentation and the wonderful answers. Thank you, everyone, for your questions, and thank you for joining us this evening. Dr. Bailey serves at 2 different locations for Rue Hurwitz Orthopedic Clinic. The main office is in Santa Barbara at 2936 Della Vina Street, and he sees clinics on the last Friday of every month in Santa Maria at the Sims Physical Therapy and Sports. For more information on both, please call 805-963-2729. This presentation is being recorded, and you will receive an email within the next week with the link to view the presentation and PowerPoint slides. A brief survey will appear after this webinar closes, and we'd love to hear your thoughts. Thank you again for joining, and have a happy and healthy rest of your evening.